So today's topic is phosphate management in hemodialysis patients and calcium and vitamin D supplementation in that. Now, as the kidneys fail, we know a deadly complication called mineral bone disease takes place in chronic kidney disease patients. See, if you see the slide, you can see that this is a complex entity with so many organ systems involved and so many molecules interacting with each other. So what is actually this CKD mineral bone disease? As the name implies, it involves bone abnormalities, then abnormal vascular calcification, and a series of laboratory abnormalities. This syndrome is called CKD-MBD or mineral bone disease. What are the things that change when the kidneys fail? First of all, it is the phosphorus. Then there is change in the calcium, then vitamin D, and to stabilize them or to maintain them as the kidneys start failing, there is change in the calcium, there is change in the phosphorus, vitamin D, and substances called FGF23 comes into play. And to correct this, the parathyroid gland, which is situated in the neck next to the thyroid, it starts producing parathyroid hormone to maintain these calcium and phosphorus in the normal range. The result is that there is bone disease as well as abnormal blood vessel calcification, leading on to the deadly complication of cardiovascular disease, high mortality, morbidity, fractures, bone pain, and so on and so forth. So this complex interaction or this complex syndrome is called as CKD-MBD. Okay, so what happens in CKD? Actually, when the functioning kidney mass reduces, we know that there is decrease in GFR. So also, there is less, the phosphorus which is normally excreted by the kidney, it's not excreted by this failing kidney. Therefore, there is hyperphosphatemia. Then comes from the bone, osteocyte, a molecule called as fibroblast growth factor that comes into play, which is anti-phosphorus. And the main purpose of this FGF23 is to push phosphorus into the urine and to maintain normal levels. Initially, it succeeds a bit, but as the kidneys fail relentlessly, there is more and more level of phosphorus, higher level of FGF23, causing less vitamin D3 and hypocalcemia, leading on to very, very high levels of parathyroid hormone secretion from the gland. This is called as secondary hyperparathyroidism. As you can see, there is failing kidney, reduced phosphorus clearance, increased FGF23, reduced vitamin D3, reduced vitamin D and D3, hypocalcemia, and secondary hyperparathyroidism. And the common lab abnormalities that you see in CKD-MBD are very high phosphorus, low levels of vitamin D, active vitamin D, low levels of calcium, and high PTH. We are quite familiar with this because many of this calcium, phosphorus, and PTH, we regularly check in all dialysis units. Always serial assessments are needed. And the target organs affected by this in CKD-MBD mainly are the kidney, bone, soft tissue, vasculature, and the heart valves. Now, the KDIGO has clearly given guidelines that one has to start screening for CKD-MBD right from stage 3 of CKD. And as a person is initiated into maintenance hemodialysis, the guideline is every 1 to 3 months we have to check calcium and phosphorus, every 3 to 6 monthly PTH, and annual alkaline phosphatase. But these are not hard and fast rules, and depending upon the individual patient, we can tailor the investigation. Now, coming to the molecules one by one. The first molecule is phosphorus, which goes high, and it is the initiator molecule of chronic kidney disease, MBD, mineral bone disease. The normal level of phosphorus in the body is 2.8 to 4.5 milligram per deciliter. As the kidneys fail, there is increased phosphorus in the blood. And remember, phosphorus is a major blood vessel toxin. It is a huge vascular toxin. How is it happening? The phosphorus, it converts the blood vessel smooth muscle cells into a bone type osteoblastic cells. And therefore, there is more and more bone type cell deposition inside the blood vessel. And this is called as vascular calcification. And there is huge vascular damage. Then there are series of events that take place, cardiac fibrosis and so on and so forth. I'm not going into the details, but remember, phosphorus which accumulates in CKD is a huge blood vessel toxin which causes so much of cardiovascular damage. Therefore, hyperphosphatemia in CKD is associated with cardiovascular and all-cause mortality. Now, the KDIGO again has given guidelines that one has to assess, serial values of calcium, phosphorus, and PTH right from stage 3A. And calcium, phosphorus has to be maintained in the near normal range in a person on dialysis as well. How to catch hold of this calcium in hemodialysis patient? It is a tough job, the main mechanisms are through dietary restriction, then dialysis and drugs, phosphate binders. Dietary phosphate in a dialysis patient should be less than 900, somewhere to the tune of 700 to 900 milligram per day. But this is not an easy job, we know that. Because once a person is started on dialysis, the doctors will naturally say you can take more of protein now. Compared to the low protein diet of pre-dialysis, we can now go for high protein. Therefore, the patient will himself say, Doctor Paranju, ishtambola protein kaitya, korchu meat and chicken vella kaitya. So, whenever there is high protein, that is converted into high phosphorus. High protein means there is high phosphorus. And therefore, an actual dialysis diet may contain up to 1000 to 2000 milligram per day of phosphorus. Phosphorus is the villain, and therefore, the source of phosphorus is very important. Plant source phosphorus, the absorption rate is up to 20 to 40% only, whereas animal source, meat products, the absorption of phosphorus is to the tune of 40 to 60%. But the most dangerous are the food additives and the carbonated drinks, where 100% of phosphorus in them is absorbed. So you definitely have to have a watch on this source of phosphorus, and you have to educate the person with the help of a good dietitian so that they can be given high protein, with reasonably low amount of phosphorus. You can get the help of a dietary expert. We always ask the dietitian to visit our unit, because these people will never go and see a dietitian, and they're also a bit reluctant. Dialysis patient naturally, they will be reluctant to check serial phosphorus as well as to get a dietary consultation. Therefore, the dietitian is often asked to visit the dialysis unit at least once a month for every patient to program a good diet and thus empower them to choose their diet in the right amount. Now, coming to the phosphorus and dialysis, even if a person takes 3 weeks, 3 times a week dialysis, we know that many of our patients are not ready. They may go for once in 4 days or twice a week dialysis. And so even if you do 3 dialysis per week, that can remove only up to 1,800 to 3,600 milligram per week of phosphorus. This is because of the phosphorus kinetics. We know that it is made, the majority of the phosphorus is inside the cells, bone, etc. And therefore, initial 2 hours of dialysis, there is some drop in phosphorus. Then there will be a static phase. And towards the end of dialysis, there is actually a 40% increase in serum phosphorus level. So whenever you think that the person is having a phosphorus value, more than 6.57 or 7.5, especially in a person who is having considerable vascular damage, like, blocked lower limb vessels, cardiovascular disease, there you can ask the patient to go for a longer dialysis time by at least few sessions of daily dialysis or extended nocturnal dialysis, so that there is better phosphorus removal. That is phosphorus and dialysis. Now, coming to the drugs, the phosphate binders. The phosphate binders are the old ones, the calcium-based binders, calcium carbonate and acetate. Then there is the non-calcium-based binder, sevelamer. Lanthanum is no more in use. Then there is iron-based binders, that is sucroferric oxyhydroxide and ferric citrate. The aluminum one is not using now. So now let us see the calcium-based binders. Calcium-based binders, they bind to the phosphorus in the food and it is excreted along with the stools. The advantage of calcium-based binder is, it very least expensive, easily available, and it can correct the calcium level in persons who are having relatively low calcium. These are the advantages. But if you keep on giving calcium-based phosphate binders for a very long time, there is always a risk for hypercalcemia. And I mentioned before, whenever there is high calcium, there is the risk of vascular calcification, blood vessel calcification, soft tissue calcification, valvular calcification, which by itself is very lethal. Therefore, long-term calcium-based binders, one has to be really careful. And over calcium ingestion can cause hypercalcemia and suppression of parathormone, which is kept a little bit high in CKD to maintain the balance of all other things. And if the PTH parathormone is suppressed too much, that is also dangerous for the system. And therefore, long-term calcium-based binders is not an option. That too, one has to be really careful when you give huge doses. Mind you, calcium is a huge gastric irritant also. When they write 111 calcium acetate, the patients will immediately come and tell you, so lots of gastritis, constipation, so on and so forth. Okay. Now, calcium acetate, each tablet of calcium acetate roughly gives around 150 to 160 milligram of elemental calcium, whereas calcium carbonate, little more, 200 milligram, 40% of calcium, elemental calcium is there. Therefore, the risk of hypercalcemia is slightly more with calcium carbonate. Now coming to the non-calcium based phosphate binders. Actually, this is a boon to many of our dialysis patients because there is no risk of hypercalcemia. It is a very safe molecule. The starting dose is 800 milligram to be taken along with the food. Little bit GI side effects are there, but absolutely there is no potential for hypercalcemia, and it has got a favorable lipid profile. Cholesterol level also will be a little bit maintained. But as expected, this is a bit more expensive tablet, but still sevelamer is found to have certain advantage in all-cause mortality. When you take the whole, the huge, the all list of phosphate binders, sevelamer is found to have a little bit of all-cause mortality benefits in hemodialysis patients. Lanthanum is not used for fear of heavy metal toxicity. Now coming to the iron-based binders, they have got ferric citrate, 210 milligram of tablet is there. Now this also binds to phosphorus in the food and is lost in the stools. This is especially good for our dialysis patients whose iron level is bit on the lower side. Because this iron-based phosphate binders, they increase the ferritin and PSAT, and there is no risk of hypercalcemia at all. But the problem is there is some pill burden is there, the number of pills and more or less at par with others. Then calcium, it is a little more expensive, and also there is a little chance for iron toxicity if it is taken for a long time. There is one more iron-based phosphate binder that is available, that is sucroferric oxyhydroxide, which here the dietary phosphate is exchanged for hydroxyl group and is lost along with the stools. The tablet strength is 500 milligram. You have to take 2 to 3 times along with meals. Here also there is no chance of hypercalcemia, and one more advantage is that the potential for iron toxicity is literally ruled out in this molecule. That is regarding the phosphate binders. Now, one word about calcium. It is said that the calcium level has to be maintained in the normal level, in the normal range, and one has to avoid hypercalcemia as per the KDIGO guidelines right from stage 3 of CKD. Now, the dialysis called calcium concentration ranges somewhere between 1.25 to 1.5. Actually, there are some preparations where you can go for low calcium dialysate as well as high calcium dialysate, but 90 to 95% of the centers are not using this varying range of calcium concentration in the dialysis, and therefore the range is usually between 1.25 to 1.5 millimole per liter. To the staff of the dialysis unit, when you take calcium blood sample for calcium for blood sample testing, remember in people with calcium very much outside the range, it is better to get a fasting sample. You should not apply pressure while applying, taking sample for the calcium. And calcium is very much related to serum albumin, and therefore you have to go for a corrected calcium by checking a serum albumin level as well along with that. So that is about the summary on phosphorus. Phosphorus is a major vascular toxin. You have to maintain the serum level near normal in dialysis patients through dietary restriction, phosphate binders, and dialysis. If the calcium level is low or near normal, initially you can go for calcium-based phosphate binders, but mind you, one has to check periodically calcium and phosphorus level. If the calcium level is already high or high normal, one has to go for sevelamer carbonate or sevelamer carbonate because there the risk of hypercalcemia and its associated vascular calcification is quite high. Now, let us move on to the second topic, that is vitamin D and the kidneys. We know that the kidneys activate vitamin D. Whatever be the source of vitamin D, let it be skin, let it be the plant source or the animal source, the final active vitamin D, called as calcitriol or 1,25-dihydroxy vitamin D, is produced in the kidney, and that rate-limiting enzyme is 1-alpha hydroxylase. But as the kidneys fail, this enzyme which produces vitamin D, called as 1-alpha hydroxylase, is down-regulated. As the GFR falls itself, there is decreased renal mass. Then there are so many uremic toxins which affect this enzyme, and therefore there is less production of active 1,25-dihydroxy vitamin D. When there is less calcitriol production, what happens is that less amount of calcium and phosphorus are absorbed from the intestine. Whatever calcium you take as diet or medicine, less amount is absorbed. Therefore, there is less bone mineralization and there is more PTH production. Vitamin D restricts or inhibits overproduction of parathyroid hormone from the parathyroid gland. But if there is little vitamin D active form as the kidneys fail, there is no restriction on parathyroid hormone production, and therefore, it goes uncontrolled. There is more and more parathyroid hormone production. And when there is less vitamin D, there is associated hypercalcemia as well. See, this active vitamin D, called as calcitriol, is a pleiotropic molecule. It is very important in the growth and differentiation of various cell types, not only in the bone or in the kidney, but also in the parathyroid gland, the vascular cells, then the blood cells, pancreas, intestine, so on and so forth. So that is a very important molecule. And if this active vitamin D3 is deficient in CKD, it causes a series of problems. Not only there is secondary uncontrolled or tertiary even hyperparathyroidism with its associated huge bone deformities, bone disease, like osteitis, fibrosa, cystica, high turnover bone disease. Then there is low mineral, then there is more fracture risk. Also, there is cardiac disease in the form of left ventricular hypertrophy, vascular calcification, accelerated atherosclerosis, progression of chronic kidney disease, cardiovascular disease, cognitive impairment, and there is high mortality as well. Therefore, vitamin D level maintenance is also important in CKD patients. For that, and also to check parathormone, we have got vitamin D analogs, which will reduce the production of parathormone by reducing the gene transcription of parathormone hormone synthesis. Actually, for renal patients, we don't use much of inactive vitamin D or cholecalciferol. We use more of active vitamin D called as calcitriol, 1,25-dihydroxy vitamin D. It is available in oral form as well as IV preparation. But, say nowadays, the need for this IV preparation is a little less, because to bring back the PTH to the range, we have got other molecules like calcimimetics, and therefore we use more of oral calcitriol, but in between we like to go for IV vitamin D as well, if there is very huge hyperparathyroidism despite other treatments. But whenever you give vitamin D3, Remember, it increases the absorption of calcium and phosphorus, and therefore there is always associated risk of not only hypercalcemia but also hyperphosphatemia. Therefore, high vitamin D means high calcium, high phosphorus. That is it. Vitamin D causes hypercalcemia, high phosphorus, this damaging molecule from the bone, high FGF23, and more vascular and soft tissue calcification. Again, one has to keep watching. Stringent monitoring of calcium, phosphorus, and PTH is needed. Moreover, there is actually no RCTs are available, showing the benefit of vitamin D or analogs in reducing cardiovascular events or mortality in CKD patients. It is useful for correcting secondary hyperparathyroidism, but the risk of hypercalcemia and hyperphosphatemia, one has to stress again and again. Okay, that is it. Again, one more common accompaniment of CKD-MBD is vascular calcification, which you have to pick up by X-rays of the lateral abdomen, hands, CT imaging or echo, where you have to look for soft tissue and valvular calcification. If you look carefully, I think you can see next to the bone image, you can see the calcified blood vessels. As if it is an angiogram, you can see the calcified blood vessels next to the bone. I hope you can see. Okay, this is a bad prognostic factor, vascular calcification, and therefore always one has to screen the patients for abnormal calcification. Because of this prolonged hypocalcemia, low active vitamin D3, very high phosphorus and FGF23, the parathyroid gland goes on producing huge amount, it will go enlargement, hypertrophy, and it will produce huge amounts of parathyroid hormone called as secondary hyperparathyroidism. We know that the normal level of PTH in the blood is from 10 to 65 pg per ml. But as the kidneys fail, the level of parathormone goes on. And in dialysis patients, it is okay or it is advisable to maintain the parathyroid hormone up to 300 picogram per ml. The KDIGO clearly mentions that too low PTH, like something less than 150, is not advised in CKD stage 5 dialysis patients for the risk of adynamic bone disease. So when there is increase in parathormone, what do? We have got certain drugs which reduce the parathyroid hormone secretion. One is, we saw, vitamin D3. Second is called calcimimetic agents, which increases the sensitivity of calcium in the parathyroid gland via activating calcium sensitizing receptor. These agents are called calcimimetics. We are very familiar with this molecule, which we very often use in the dialysis unit, called a cinacalcid, which will reduce the secretion of parathormone from the parathyroid gland. Oral formulation is available starting from 30 milligram dose. You have to take it with food. There are minor GI side effects, but the most important side effect is hypocalcemia. Cinacalcid, the calcimimetic agent, which is used to reduce uncontrolled parathyroid secretion by the parathyroid gland, can cause hypocalcemia. And if the calcium level is 7.5, it is dangerous. One has to stop cinacalcid because it can cause hypocalcemic seizures, arrhythmias by causing QT prolongation. And the dialysis personnel, please note, when you are checking for parathyroid level, for a person who is on cinacalcid, one has to test at least 12 hours after the last dose of cinacalcid. Okay. The PTH lowering therapies available are the calcimimetics, calcitriol, or in selected persons, we can go for a combination of calcitriol and calcimimetics as well. Now, coming to the clinical syndromes in CKD-MBD, there are mainly two types of bone disease. One is called high turnover bone disease associated with high PTH level, and second is low turnover bone disease associated with low PTH level. That is otherwise called adynamic bone disease. A variety of causes contribute to this adynamic bone disease, of which I will mention a few. very low PTH level. If one is very enthusiastic to bring the PTH level, I mean, to the normal range of 65 or so, it is dangerous in a dialysis patient. So PTH up to the tune of 300 is very much okay for a dialysis person. And if you bring the PTH to very lower tones, like, less than 100, especially if associated with high calcium, that's a natural correlation. High calcium, then high dose of vitamin D, this can cause, and high levels of cinacalcid, which will cause very low PTH. This will literally abolish new bone formation, and this is called as adynamic bone disease. It has got its own bundle of complications like, extreme bone fragility, fractures, bone pain, and cardiovascular mortality. So we have to be careful not to bring the PTH to very low levels also. This is just a slide to show that when you give a calcium-based binder, the calcium level increases, all others, phosphorus, the calcium phosphorus product, previously we used to say it has to be less than 55, So the product and the PTH, everything will come down. Calcium-free binder like sevelamer, calcium is unaffected. Phosphorus, the product of calcium and phosphorus and the PTH is reduced. The vitamin D will increase the calcium level, it will increase the phosphorus level and the product as well, but it decreases the parathyroid hormone level. Whereas cinacalcid, the calcimimetic, reduces calcium, phosphorus, and the PTH. I don't want to confuse you. I hope you understand something. Okay. So actually, all our dialysis units, we have got wonderful protocols telling that we have to check calcium, phosphorus monthly, PTH 3 monthly, all these things are there. And our very sincere dialysis personnel, they do test all these values, but many often we forget to follow them up. That also happens. Patient may be taking old prescription for weeks or months. So it is very important to consider the values in the context of the clinical context of the patient, and you have to appropriately adjust or update the prescription depending upon this serial change in the values of these parameters. Therefore, what I want to point out is that we know that CKD is on the rise for various reasons, and it's one of the deadly complications of chronic kidney disease is mineral bone disease with its associated cardiovascular mortality and morbidity. One has to catch these patients early in the disease process through labs as well as the screening of vasculature. We have to do lab values, and serial values are important. Whenever we are using calcium, vitamin D, and anti-PTH therapies like cinacalcid, we have to use them very judiciously without overshooting or underplaying. Okay. And the most important thing is that phosphorus normalizing is the most important factor, because phosphorus is the initiator step in the process, in the pathogenesis of CKD-MBD. Many a time our patients may not be willing to repeatedly test these things, but we have to approach them with empathy and make them understand the importance of this complication, which has got a huge impact on the long-term longevity of the patient. Therefore, to summarize, before winding up, calcium should not be too high or too low. Phosphorus, the major villain, the major blood vessel toxin, as normal as possible. And PTH, not too low, not less than 150 or not more than 500. And let us see the KDIGO guidelines like phosphorus near normal, calcium, avoid hypercalcemia. That is very important. Corrected calcium should be checked whenever the calcium is very much out of range. And again, parathormone in the range of 2 to 9. Thank you.